Hello, everyone. Happy Thursday yet again. Thank you for taking the time to hang out with us for this hour, or probably a little bit longer than an hour because our beloved VJ is back with yet another VJ case, which means we'll probably bleed over. Um, but for those of you who don't know VJ, he's been part of VMR for a very, very long time, probably since its inception, and has bamboozled us with many a case, including most recently a case of many infections um, in many unusual places that I don't want to spoil for you. You should totally check it out on YouTube. Um, but thankfully, I will not be alone to discuss a VJ case, and will be accompanied by also somebody who I've known for a long time, and somebody that you all probably very likely know. And today, in the lukewarm discussant scene is Mengyu, who, good for her, is not taking a final exam in math, but rather just hanging out today. And she'll tell you a little bit more about that story. But we've been so excited to have Mengyu involved. As I alluded to, I got to know Mengyu 3 or 4 years ago when we overlapped at UCSF and learned of her love for clinical reasoning. But it took a long time for our forces to collide enough for her to join the academy, and she's been part of the academy for almost double-digit months, not quite yet there yet, but is cruising in her facilitation of student VMR, where I imagine you see her most, but also on Tuesday VMRs. And I also learned that she is not so low grade mentoring and helping our academy members, and actually helped one of our academy members get a really precious interview that was really valuable to her. So your tentacles are long and wide, my friend Mingy. We're very, very excited to have you here. I'll pass the mic for you to say hi and maybe to contextualize my math comment.
Yeah, that was really funny. I was just reflecting how I feel today, and then suddenly remembered I had a dream last night about having an upcoming maths test, final exam the next day, but not prepared, and panicked in my dream. But I'm also excited. I think that I admit feeling a little bit nervous. I think that nervousness comes from the fact that I've been a few years into practice, but often recognize the often all inspired by the team members' advanced clinical reasoning skills, and recognizing that I have knowledge gaps, which I think if I hit those knowledge gaps today, which I'm sure I will, I'll just exercise my growth mindset and focus on turning that into learning opportunities.
I love that mentality, and I agree with you. The probability of a knowledge gap for both of us today is 100% knowing VJ. VJ, you want to say hi before we jump in?
Hi everyone, this is Vijay. I'm currently doing my residency in pulmonary critical care from India. Uh, it's been great logging after a long hiatus because of a busy residency. Uh, I think the best part of CP Solvers is you get inspired seeing the clinical reasoning that goes into uh, whatever we are doing here. So it has been just inspiring seeing so many people behind this. So, uh, and excited to present a case back.
Vijay, I want to thank you for sharing that. I'm learning to try to get as close as I possibly can to pronounce people's names. Can you say your name one more time? Because I think I've been pronouncing it wrong.
Vijay, it's perfect.
Vijay. Vijay.
Yeah.
Okay. All right. That's super helpful. All right. Well, take it away, my friend.
Yeah. The title I have given is Gene or Anatomy for this case. So presenting a case of an 18-year-old male who presented with worsening dyspnea for 3 days. Coming to the HPI, patient was completely doing fine when he suddenly developed breathlessness when he got up to climb the stairs, which progressed over 1 day such that he was unable to walk even a few steps. And associated with this, he had left-sided chest pain that was dull aching, predominantly in the anterior chest, worsened with deep inspiration, and had no relation to food or any exertion or emotions. Few hours later, he also noticed some episode of lightheadedness. Here, there was 2 episodes of lightheadedness transiently that occurred for about 2 to 3 minutes, during which he had no loss of consciousness. or any involuntary movements at this point of time. He also had some exertional palpitations during these episodes for about 3 days. He denied any orthopnea, PND, or any recent fevers. I'd stop here.
Amazing.
Wow.
What a great start. Mengyu, I'm curious, just to kind of tap into your thoughts. We got a lot of information here, but I'm really curious what your mind is doing in terms of trying to not necessarily analyze it, but like how you would share with us where you're starting and what your reasoning might be to start where.
Yeah, I think first it's an 18-year-old man, so like a young person, that made me think about the framework of the bad behavior and bad genes. And but then I think with the chief complaint of dyspnea, I immediately had the respiratory distress pyramid in my mind, which with the bottom layer being lung, and then above that is heart, and then also bad blood, no blood, and acid-base disorders. But then with the chest pain complaint come into play, I then centered around the cardiopulmonary. And with this description, which sounds like a pleuritic chest pain, I then think about mostly pulmonary, especially with then the additional lightheadedness and what are the other of fainting, or yeah, I was thinking about PE as something that we have to rule out. But also other causes of pleuritic chest pain, which is also often associated with shortness of breath. So those are where my mind is right now, I think.
I completely agree with you. I had a similar arc, honestly. I was a little bit surprised that an 18-year-old developed shortness of breath, in large part because of how uncommon this is in otherwise young people. But then, actually, to be honest with you, even more surprised that it was abrupt in onset. Because if we're taking the caveat that an 18-year-old is gonna get an illness severe enough to compromise their cardiorespiratory status, if we're gonna subselect for that population, I would venture to guess that the vast majority of that population has a subacute to chronic vulnerability to that shortness of breath. And so I think it's the age of the patient is super interesting and probably very rare. But also, I would argue that the acuity is even rarer within that population. And to emphasize that point with a little bit more clarity, if you are 18 and you're going to get shortness of breath, you probably have a disease process that is unique enough that it probably leaves you with an underlying chronic imprint. And so how does that change my thinking right now? It changes my thinking to be a little bit more precise in my history, because all too often, I think we jump on the train of the history and move forward. This is a time to really scrutinize one key aspect of this case, which is 3 days ago, you were fine. But what do you mean by fine? Are you able to exert yourself to a level that is similar to your peers, or have you gotten used to something and now have accepted a new baseline? So for me, I'm so interested in establishing and understanding what normal means for this person and whether it is equivalent to the people he is surrounded by. I'm curious, you latched on to like a really high concern for pulmonary embolism, and I'm right there with you. If you had to like disentangle what took you to that diagnosis, what were the sequence of events in your mind?
I think part of it is the availability bias, that we have so many cases of pulmonary embolism that presents kind of this way. But then also I think the combination of dyspnea, lightheadedness, and chest pain. So that is definitely on differential. Although like other differentials in my mind includes like pneumothorax, which can happen if there's any underlying process in a young person. Yeah, I think that's kind of just because it's a can't misdiagnosis. So that's why it came to my mind first.
Yeah, super. I completely agree with you. I think that we've often reflected on what the value is of chest pain in a patient who's short of breath. And I think the way you started was awesome. Like shortness of breath, the lung, the dyspnea pyramid, lung at the bottom being the most common, then the heart, and at the top. And if you ask yourself, like, what is the value of chest pain? And I think what really happens in the context of chest pain, in my opinion, is that if you're experiencing the combination of the two, you'll probably have a deeper process in the chest. So, for example, if you have an airways issue from COPD or a pneumonia without infarction, you're probably just going to be short of breath. But if you have concomitant chest pain, the probability of pleural involvement in the form of an empyema from a pneumonia or infarction from a pulmonary embolism or involvement of the pericardium or involvement of the heart itself becomes higher. So for me, I think that the fact that this person also hurts makes me worry that not just the lungs are involved, if they are, but something deeper in the pleura or in the pericardium or the heart. So the depth of the problem, unfortunately, becomes higher. I think it's also probably very valuable to take stock of the fact that it is unilateral. And we talk a lot about cardiac chest pain being on the left side, but actually the Core IM podcast taught me to dismiss that hypothesis. And so if we're saying that this person has left-sided anterior chest pain, I think the money is invoking the left pleura or the pericardium. So chest pain plus shortness of breath means that the process is probably deeper, and the suspicion for a pleural left-sided or pericardial process is really high. And whenever you're thinking about a pleural or pericardial process, you have to think, is this pleural infarction or a pericardial effusion? So for me, these are the two no misdiagnoses in this person. Is unlike the usual pathway for chest pain, where we kind of take some time to get the workup and whatnot, I think the distance between us and imaging to clarify whether this person has a PE or a pericardial effusion is very, very narrow. And I'm curious, Mengyu, do you think that you would order it off the first pass orders that you put in if you were the person taking care of them, or would you wait for more data to come back and then reassess your CT scan capabilities? What do you think?
I think I might start ordering some basic tests, including a chest X-ray, and might do a point of care ultrasound.
Yeah, no,
I guess it's reasonable to start some tests. Yeah.
Yeah, I think there's no urgency. It's been going on for 3 days. I think what everybody would agree on is you're probably not going to wait too long to look for a PE if you don't find it otherwise. But I think that unlike acute coronary syndrome and aortic dissection, you do have a few hours to diagnose a non-massive PE. And so I think you can hear in Mengyu's thinking that, yeah, you've thought of it clearly. But unlike ACS and aortic dissection, the thought doesn't translate into immediate action because you recognize that PE gives you a little bit of time to diagnose it. Cool. All right, VJ, we'll pass the mic to you to give us some more information.
Amazing thoughts. Coming to the past medical history, patient was diagnosed recently 2 months ago with an unprovoked intermediate high-risk pulmonary embolism, which was involving the left main and the right lower lobe segmental arteries. He was discharged on rivaroxaban of 20 mg. At that point of time, the workup was negative for an APLA, prothrombin gene, and activated protein C resistance. Coming to the social history, he's an active young male. He denies any addictions. Family history, there is no history of any family history of similar complaints in the family, or mother suffering with any recurrent pregnancy losses, or any and the systemic review of systems is negative for any rashes, any significant loss of weight, loss of appetite, or any inflammatory signature. I think I'll stop here.
What did this do for you, Mengyu? Where are you at now?
I think I'm hearing the history of recent diagnosis of PE and on treatment, but the symptom currently is still pretty consistent with a PE, maybe like a worsening PE. So that is definitely still high on my differential. Although then the question is the PE not responsive to treatment, or is it a completely different process, either as a complication of treatment or complication of the underlying process that causes both PE and the current problem. And did I also hear like protein C resistance, something like that, like the workup for, because I think it would be, if it's unprovoked, would be.
It was negative for APR. So reason we did this was because factor V Leiden upfront is a little expensive, so we did a screening with an activated protein C resistance.
Mm.
It was
So,
negative. All of that at that point of time was negative.
oh, it was all negative. Got you. Yeah. Because then my first thought is there any underlying hypercoagulability reasons for him to have this unprovoked PE? Those are my reflex thoughts right now. But
Yeah, no, I'm right there. I'm right there with you. And I think it's since we're both on the same page, I think VJ is setting us up for a conversation to have, maybe not so much about clinical reasoning, but just to share our both our experiences with with if we were there at the first hospitalization, what kind of workup would we obtain, at least that would be what our practice pattern would be in the US. So I'm curious, Mengu, what your practice pattern is when you have a pulmonary embolism, how you might teach us about who do you work up, when do you work up? Like, what are your sort of, as a generalist and a hospitalist, what your workup usually is for these folks who have pulmonary emboli?
yeah, I think, well, a lot of times we defer to outpatient because I know that a lot of the workup are not accurate in the setting of acute infarction or if the patient is already started on anticoagulation. But I think the things that are still reliable is factor V Leiden gene test and the antiphospholipid test. But otherwise, I also heard a recent grant round from UCSF about anticoagulation and I think for hypercoagulability workup. I had the impression there's like a layer of if there's no typical risk factors, then these people definitely need some tests or some things like that, like a layered test, category-based test strategy. But I think a lot of times the patient would have tests after the course of treatment in the clinic with hematology or PCP follow-up.
Yeah, I think that's absolutely superb. And I think it's so captured in your sentence about the fact that it's usually an outpatient workup. I think that as you alluded to, I'll just kind of rephrase it in the way my mind breaks it down, which is the first words that are often applied with a pulmonary embolism is its severity, like how bad it is. Is it massive, submassive? The severity of the pulmonary embolism does not influence the diagnostic workup. So that's the first sort of recognition, is the how bad it is doesn't tell you how its hemodynamic consequences doesn't give you insight into the underlying possibility. What instead VJ is teaching us is the word provoked or unprovoked gives you a sense of the underlying cause. So in patients with a provoked pulmonary embolism, there's this notion that a provoked pulmonary embolism can happen to any person in the world. Any human being can get a provoked pulmonary embolism. So the idea is that the disease is driven by the trigger. So you can get a pulmonary embolism because you had really bad surgery, extensive surgery, or really bad trauma, or depending on the severity of the trigger, a long flight, so on and so forth. So when we say that the pulmonary embolism was provoked, what we're trying to say is that we believe that the trigger is the problem and the patient has no severe underlying risk factor. And so if we treat the patient for a short period of time, the body will take care of the clot, and all we have to do is to make sure they don't experience the trigger again. Or if they're about to and we can't help it, then we give them some temporary management, temporary anticoagulation through the trigger. So a provoked pulmonary embolism is managing the provocation and temporarily anticoagulating the patient. In an unprovoked issue, unprovoked pulmonary embolism, you're like, well, what can I do to prevent the patient from getting a clot again if it just came out of the blue? And that kind of very simplistic thinking is actually drives most of our diagnostic workup, which is if you're saying that I can't do anything about this, it just came out of the blue, the patient will probably need lifelong anticoagulation. So if the patient's going to need lifelong anticoagulation, well, why bother with a workup? It's a very fair question. And I think the answer to it is it's actually very nuanced, because it could have implications for the patient's family members. It could have implications for the detection of an underlying disease that the pulmonary embolism is a clue for. But I think you just have to be very simplistic and say, if it's unprovoked, the patient's going to need lifelong anticoagulation. I care because of some kind of maybe not immediately overt reasons. And so if if it's unprovoked, you're going to anticoagulate the patient, and you are going to pursue a workup. You're pursuing a workup to mitigate, not because you're not going to stop anticoagulation. You probably aren't, but to help screen family members and to help to detect another diagnosis with even more consequences, such as metastatic cancer. So here's the punchline. If the patient is showing up with an unprovoked pulmonary embolism, but leaves you no other clue as to the cause of the pulmonary embolism, then you're probably not going to find the cause. So if a patient shows up with a unprovoked pulmonary embolism and has no weight loss, no anemia, no sign of cancer, what are the odds that you're going to find a patient with a metastatic cancer with the only symptom being a pulmonary embolism? Very, very low. So guidelines have encouraged us to actually take this patient, remove the pulmonary embolism from the clinical picture, and examine them, talk to them, and get basic laboratory history like we would do in any other human being. And if that gives us clues, they've had heparin recently, they have weight loss recently, analyze the case agnostic to the pulmonary embolism and see what that takes you. That is the most productive pathway to understanding why a patient developed an unprovoked pulmonary embolism. And there's only two things that you have to do with excessive focus. And those two things are a really good family history and a really good pregnancy history. The family history is to detect really bad genetic mutations, and the pregnancy history is to make sure that you're not missing recurrent non-thrombotic manifestations of antiphospholipid antibody syndrome. So long story short, the workup that this patient got is actually more than you might do in most people, unless VJ was following clues saying, there's a prominent family history, or the patient had weight loss, or actually the patient has had 7 thromboses so far with no clear cause. So that's the 10,000-foot view that I have. I'm curious how that jives with you and whether that fits your working model, Mingyu.
Yeah, totally. Definitely, like I think asking one part of the history is asking if there's any factors that might have provoked. Although it sounds like from VJ's history, it's already concluded as unprovoked. So then, kind of next step, would be reasonable to understand the underlying reason, which will have implications on the subsequent management. Yeah.
Love it. Alrighty, VJ, tell us more, please.
Coming to the vitals, so his BP was 104/70, heart rate of 128, respiratory rate of 34, saturation of 92% on room air. Physical examination, there was occasional crackles in the left infrascapular and axillary areas. Other than that, the systemic examination was unremarkable. Coming to the labs, HB was hemoglobin was 13.7, WBC of 12.9 with neutrophil of 53 and lymphocyte of 30%. Platelet count was 1.1 lakh. Significant labs where the prothrombin time was 12.7 with an INR of 1.03. APTT was mildly elevated, 40 seconds. The lab cutoff was 25. The liver and the renal chemistries were normal. The troponin was positive. The high sensitivity tropi was around 100 here. The ECG showed sinus tachycardia. So I would stop here.
Oh, Mingyu, I'm a little worried. Where are you at?
Yeah, I think the heart rate is pretty fast, which raises the concern of more severe PE if this were PE. And then although the oxygen saturation is maintaining, I think still kind of have to assess the severity, the extensiveness of the clot burden at this time. And I don't know about the crackles in the left capsular areas. If there's any lung infarct, I assume that could produce some abnormal auscultation findings, but I think imaging would help clarify what that is. But then otherwise, I think the labs or I don't I think the troponin definitely also points toward the possibility of significant PE burden with the EKG not showing any ischemic signs. So I think the ACS concern is a little bit less likely, but would be reasonable to trend to just make sure. And the platelet, I mean, don't know what to make of it too much yet. And I think the coagulation panel is hard to interpret in the setting of being on rivaroxaban, assuming he's taking it. So could just be the mild prolongation could just be explained by that. I think those are where my thoughts are right now. And the respiratory rate for sure, along with the heart rate, also points toward the PE.
I completely agree with that. I have nothing to add to your thinking. I completely agree with everything you're saying. What do you think you might do in this setting? What would be your next steps, you think?
I think would get a CTPE and to compare with the prior and to assess if there's any right heart strain. And if that's the case, then would call the PERT team and then switch the rivaroxaban to a heparin drip or something, presuming that he may fail the rivaroxaban. I mean, if the finding confirms a larger PE.
Yeah, I know. I completely agree with you. I think this is a very, very high risk situation. And the truth is that if you were seeing this patient for the first time, if you were seeing the patient before you got the labs, to go back to that original question of when is it a good time to get that CTPE? I mean, if you see that somebody has pleuritic chest pain, has a heart rate of 128, has a blood pressure of 104, and has a history of pulmonary embolism, you have two options. You can wait for the hour and a half that it takes for the labs to come back and then get a CT, order a CT, and then wait another hour, 2 hours until the CT is done and resulted, or you can get it right then and there. And I would argue that efficient and accurate clinical reasoning in a patient like this would mean that you get a CT scan at the end of the exam, because we're talking about 3 hours probably in a patient who is looking like they at least have an intermediate risk pulmonary embolism, if not evolving into a high risk pulmonary embolism, given the borderline blood pressures here. So my only advice, honestly, is to continue to be thoughtful, not just about what the diagnosis is, but especially in some considerations, how quickly to obtain it. I think we both overget and underget pulmonary embolisms because it's such a hard diagnosis to fine tune. But in this patient, I would argue the threshold has probably been crossed at the physical exam mark. And you can see how little the labs change your thinking now as we do that exercise. All right, Vijay. If the CT doesn't show a PE, we're in deep trouble here, but the patient hopefully will benefit from it. But
I
yeah,
just wanted to share the CT just to show the comparison between the previous and the current one. Could you just make me a
yeah.
co-host?
Let me make you a co-host. One moment, please. Sorry about that. I should have done that earlier. All right, I think you should be able to now.
Is my screen visible?
Yes.
So this was the CTPA that was done. This was the initial CT on the first admission 2 months ago, and this is the current CT.
Oh, wow.
Okay, so I just thought I would this significant findings here were initially uh, the patient had a left main, the thrombus in the left main and the right side. Here we can see it here. So on anticoagulation, this side it is on the left main is fairly resolved. but what was alarming was here. So here we can see this is the right upper lobe segmental pulmonary artery. So here there is a new thrombus that has been here, and there is a cut off the near the bronchus intermedius. So that part has a distal PE in the middle here as well as the lower lobe. So new onset pulmonary embolism in the right upper and middle lobes, segmental pulmonary embolism. With we can see evidence of an RV strain here with an RV by LV ratio of more than the RV looks bigger than the LV. Like we were discussing about how to explain the chest pain, what happened to the pleura? So in fact here this is just the lung windows. There is a new onset infarct in the left lower. So diffusely there is some mosaic attenuation. So this one here, this was a new onset infarct. So that was probably what we're considering the chest pain. But there is something that was more interesting. I think this would be the part of the third aliquot as well. So this was the point of care ultrasound where this is the inferior vena cava. Okay.
Oh, I think you might have to share one more time. Sorry.
Okay. Okay. So this was the point of care ultrasound we did for the IVC. So we found something here like this. This is the renal artery. So just at the branch point of the renal artery, we see has a mobile hyperechoic structure, probably consistent with the thrombus. So this is, I think I'll stop here.
Wow. All
Mhm.
right, Mingy, what are your thoughts now? Really
Yeah,
tricky.
becomes tricky and interesting. I think first when I saw the CTA, I was surprised to see that the left-sided PE actually seems to be resolving or improving, but then there's new right-sided PE, if my understanding is correct. So I thought that's interesting because can't say if the patient is, I mean, almost like patient the rivaroxaban is not working, although the left side is improving. And then there's then VJ showed us this amazing ultrasound showing arterial thrombosis, right? Like near the renal artery.
That was a inferior vena cava. That was an inferior vena cava. It
Oh,
was a
sorry. Oh,
thrombosis. The
oh, okay.
IVC.
Oh, yeah, right. So it's near the renal vein. Right. So then another clot formed. Oh, thank you, VJ, for preparing these amazing slides. And so I think that my thoughts are, I think I'm feeling a little puzzled. So I kind of go back to the triad of like hypercoagulability. I think we can call it hypercoagulability, which is either the vessel problem or a blood problem or what so like so thinking about the blood problem, I think some of the most important workup or negative like antiphospholipids. So might consider repeating those lab, but I think those might be limited at this time. So I'm not sure about that. And then thinking about another vessel problem. So thinking about the source of the clots, like coming from the legs or so like when I think about anatomy problem, I would think if there's any underlying, when I see a venous thrombosis near the renal vein, my first thought is like if there's a cancer thrombosis, although in a young person that seems to be quite unusual, like a renal tumor causing that, but I think that seems a little unusual. But if there's a really significant underlying hypercoagulable state, then there are certain conditions that rivaroxaban would not help, which include, I think for cancer, there might be some debate. I think most of the time it still works, but I guess depending on the type of the malignancy, it may fail. But then antiphospholipid, another one that you have to use warfarin instead of DOAC. I'm sure there are some knowledge gap I have here where either a condition that the rivaroxaban will not be covering that I'm not aware of, apart from cancer and apart from antiphospholipid, or there's just thinking back on the title of the case, like there's a certain kind of anatomy or a kind of injury that sorry, I'm just rambling at this point, feeling a little bit clueless with what the next step would be.
I think probably everybody would be at wit's end about what to do because clotting on anticoagulation is such a rare event that it triggers bringing in the most seasoned experts in this scenario. And I think what you said it earlier is that if he's taking it, and I think that's such a key thing because you could imagine that he has a unprovoked pulmonary embolism and is not taking the medication. It's a big difference if he is. And so that's the first step, is asking ourselves, what is our schema or approach for a patient who's having clots on anticoagulation? I think you said it all. The first step is, are they taking the medication? And even if they are, is there a drug-drug interaction that is impairing the efficacy of the medication? Is there a malabsorptive syndrome going on? So in these instances, knowing whether or not he's therapeutic is key. That you might get a factor 10A level just to get a sense. Although, as you alluded to, his mildly perturbed coagulation pathways are enough to invoke the possibility that he is in fact taking it. So if we assume he is taking the med, what's the other possibility that may be not so serious? Is actually a clot mimic. This is really, really important in certain circumstances like that, to kind of zoom in right now on what you know. We don't know that he has clots. What we know is he has a filling defect in the IVC and in the pulmonary artery. Does a filling defect equal clot? In most cases, it does. But could he have renal cell carcinoma going into the IVC and flicking off clots that are tumor thrombus and not bland thrombus? Tumor thrombus doesn't care one bit about anticoagulation because it's not clot. So the two things that I think of, Mengyu, in a patient who's clotting on anticoagulation are the two M's. Med, is it on board? Or a mimic? Is it something else that's causing a filling defect? However, this schema and this approach is also illustrative of a very important concept in hypercoagulable conditions, which is there are some conditions that are a little bit hypercoagulable, like protein C and protein S deficiency and factor V Leiden. But those conditions don't stand a chance in a coagulability battle compared to APLS or a heparin-induced thrombocytopenia or cancer. They're children compared to those adults. And so within the world of hypercoagulable are these conditions that I've come to call ultra hypercoagulable, where they clot through anticoagulation. So I'm just going to show you two visuals that I'm not supposed to show you because they're supposed to be exclusive for our RLR CP Solver subscribers, but whatever. And so here's the first visual, just to anchor our conversation. Share. By the way, I highly encourage you to subscribe to RLR CP Solvers. It's cool. That's my plug. Here it is. First, think of the two M's. And is it a mimic of a clot? And then move on to the ultra hypercoagulable conditions. What are these ultra hypercoagulable conditions? On rlrcpsolvers.com, not only do you get a sneak preview of this video, you get a whole video explaining the schema in rich detail and a case that comes along with it. Here, my plugging skills are getting better. Here is not the full schema of ultra hypercoagulable conditions that we'll have to think about, Mengyu, but a small list that is filtered by sneaky but ultra hypercoagulable. And we've titled it cryptic ultra hypercoagulable conditions. On rlrcpsolvers.com, you can find the full schema. But here they are. You said them all already, basically. An occult cancer, seronegative antiphospholipid antibody syndrome, masked P. vera. P. vera with splenomegaly can reduce the hemoglobin. Mark presented this case, eosinophilic myocarditis without eosinophilia, which is crazy. But here are the ones that are the super sneakiest, the pipes. If you have thoracic outlet syndrome because you're tall and thin, this person's definitely thin, there's no adiposity on their chest whatsoever. Or if you have an IVC web or a Chiari malformation or something that is compressing your veins, no amount of anticoagulation is going to fix that. If we've learned that he has recurrent mouth and genital ulcers, we might have to think about Behçet's. So where am I at, Mengyu? I'm right where you are. I'm really curious if the med is on board. I'm really curious if this is a bland thrombus or actually a tumor thrombus. I would send a myeloproliferative neoplasm workup and repeat APLS serologies. I would ask the patient about any history. Give me anything, especially about ulcers. But I think I'm most worried about the possibility that there is occult compression here. And the rationale for that is the occult compressive syndromes leave no other fingerprint than clot after clot after clot after clot, in stark contrast to cancer, which has many extra thrombotic manifestations, in stark contrast to APLS, which has many extra thrombotic manifestations, so on and so forth. So super cryptic, but only hypercoagulable without any other clue screams to me a structural anatomical issue, which I would evaluate in excruciating detail, beginning with the physical exam and seeing, does he have bulky shoulder musculature? Does he raise his hands and does he write on a whiteboard and teach? Does he use a bicycle or bike a lot, compressing his pelvic veins? So those would be the things that really, really zoom in on. I've talked for a lot. I'm curious what thoughts, questions, or other ideas you've accumulated since this ramble and plug.
Oh, I love that visual and the way to organize when patient has clots while on anticoagulation, and especially the anatomy part. I think is where a space where I'm less familiar and haven't really encountered a case to. So I think this case will be a great learning for me, and yeah, I'm curious to see how we can explore that possibilities. Yeah, other than what I think based on other than what you already said, getting more history and analysis. But I think compression, I would imagine there will be some imaging involved in assessing those structures.
I completely agree. All right, Vijay, what do you have next for us?
Amazing thoughts. So this is something similar that we were going through because we were concerned patient is having a new thrombus on anticoagulation. So I pulled up the same similar schema that to solve this practically this case. One thing was we repeated the drug. We just wanted to make sure the drug was normal. So especially rivaroxaban, it has to be taken with food. The patient was taking it with food. There is no other significant. So he was able to do. There is no any rashes, oral ulcers, nothing of that sort. There was no any weight loss. He's able to do all his activities. The upper limb, lower limbs were completely fine. So this patient, we started on an apparent drip. So the further workup, we were concerned for if it could be a seronegative EPS or an occult malignancy. So his lupus anticoagulant, the lupus anticoagulant came positive. The beta-2 glycoprotein 1 was negative and an anticardiolipin was negative. His homocysteine levels are borderline elevated, 30. The lab cutoff is around 17. The MTHFR, the methylene tetrahydrofolate reductase enzyme, was negative. His urine microscopy showed no active sediments or RBCs. His P ANCA was sent, which was 1:20, which is positive. However, the anti-PR3 and MPO antibodies were negative. We got a CT venogram because we are concerned for a possible compression syndrome. The CT venogram revealed a nutcracker phenomenon involving the nutcracker phenomenon with prominent left gonadal veins and multiple venous collaterals, with compression of the common iliac vein of more than 60% between the right common iliac artery and L4 vertebra. And this is a linear floating thrombus that was there. So, we have the final diagnosis. So the patient had a coexisting, probably a May Turner, which was asymptomatic because he didn't have any lower limb DVT. So, so patient had a low risk APS with May Turner. So patient was switched to warfarin, and so after about 2 weeks, we did a follow-up, and the IVC thrombus were completely resolved. So at the time of managing this patient, we had one concern of should we go for a catheter-directed thrombolysis of the IVC thrombus, because it looked like a large floating thrombus. However, after speaking to the interventional radiology team, they opined on considering anticoagulation and then to take it further if there was any worsening. So luckily the patient did well, and currently he's completely fine.
I don't know what to say, VJ. You always come up with a 1-2 diagnoses, not 1 but 2 every time. Mingyu, what are you thinking? What are your thoughts?
Yeah, well, shout out to AMK. I saw she mentioned the May Turner syndrome. So I when you mentioned anatomy, I think that was something that I at least have heard of. And and VJ, actually, I missed that. Did the patient have a stent or something placed to fix that narrowing?
So because this patient didn't have any significant lower limb symptoms, so we were not sure that this is the IVC thrombus really because of the underlying May Turner. So we have kept him for follow-up. By chance, any symptom develop, because patient is currently asymptomatic. So any worsening of symptoms, we are planning to go for a stenting.
Got you. Wow, that's a great case. I think I learned to have an approach to cases like this, and but also I think I'm still reflecting on the positive antiphospholipid. So just trying to reconcile the case, like the positive antiphospholipid was steamed like on repeat. I wonder if it's still positive, or was it deemed a nuance in this case, or is that a contributing factor if it's still positive on repeat? I might have missed some of the information.
Yeah, I missed mentioning it. So it was repeat. So twice repeated was true positive. The lupus anticoagulant was positive. The other two were negative.
Oh, so it's positive twice. Then with
Yeah.
the symptom seems to then suggest the diagnosis of antiphospholipid, which then he would need a different anticoagulation. Yeah. So is there like then 2 possible etiologies of this what happened to the patient, like a combination of, but mostly driven by APLS, but then that could the nutcracker, the May Turner would be a source, the initial trigger. Wow.
I think, Mingyu, it's so symbolic of your desire to become the best version of yourself by the degree that you're scrutinizing the details to understand what really to upload. And I'm in a similar situation with you. I think there's one piece of knowledge that we should just say outright, which is that a, a compressive radiology does not mean a compressive syndrome. 90% of people who are imaged who are found to have May-Thurner anatomy do not have May-Thurner syndrome. Many of us will have incidental compression of the iliac vein as a result of the iliac artery, or as a result of a bony osteophyte in older adults. So this person has antiphospholipid antibody syndrome, as you mentioned, because of the repeat positive of lupus anticoagulant. Lupus anticoagulant is the most specific of the three antibodies that we get. The beta-2 glycoprotein is second best, and the anticardiolipin is third best in alphabetical order. A, anticoagulant; B, beta-2 glycoprotein; and C, cardiolipin. Thankfully, the world makes some sense sometimes. But what to do with the compressant syndromes is actually very tricky. Are they a trigger for APS, or are they true and unrelated? And I think that we have two compressive syndromes. We have compression of the iliac vein in May-Thurner, and we have compression of the left renal vein, termed Nutcracker syndrome. I'm much more inclined to believe that the compression of the left renal vein is of clinical significance, because unlike the leg, which is unaffected by the May-Thurner physiology, the left renal vein has consequences, and it's causing gonadal dysfunction of the gonadal veins, proving that there's consequence of that anatomic obstruction. So I think the question is the left renal vein the source of the thrombus? But either way, I think VJ has proven that with improvement with warfarin, superior to DOAC in patients with APS, means that you can take your time to figure out, is the compressive syndrome symptomatic or not? But that's a very, very complex conversation. I'm curious, VJ, what was your and your team's analysis of the significance of the Nutcracker physiology?
So we were not able to get any cause for the compression. So we were thinking probably it is the congenital cause that could have caused the probable IVC thrombus. Because the Nutcracker is more significant than, like you alluded to, the May-Thurner physiology per se, which is normal in normal variant. So here we thought we'll, for now, anticoagulate the patient, and on follow-up, if it is something similar because it's a structural lesion, maybe we'll have to go for an interventional procedure. So that is what, because decision making was hard because there is no clear-cut way to go through this. So this was how it went through.
Absolutely amazing, breathtaking case. Honestly, I think not just because the patient has had their breath taken, but thankfully restored by your excellent care, but also a real powerful journey that illustrates how you can have such bad thrombosis in isolation without a company that usually gives you the clue. And studying these syndromes is life-changing for these patients. Mengyu, I'm curious, how was it to discuss this case? What are you left thinking, and what do you feel like you reflect on afterwards?
Thank you so much, VJ, for this case. I feel like I learned so much, as well as Rabih's sharing of the knowledge and your schemas, and think really helped me extract the diagnostic approach from this case, and reflect on the complexity of a case like this. Also reflect on how Rabih guided me through the case, and point me towards the direction of the discussion. So really learning so much from this case. Thank you so much.
You know, Mengyu, I just have to say that I think historically these Thursday VMRs were a lot about elevating our younger students and residents. And I think I don't know if you know this, but I think you literally changed my approach to these sessions, because I used to feel a little bit intimidated and scared by like co-discussing with a fellow attending. And in medicine and academic medicine, there's a lot of like weirdness around having these kind of tough conversations and discussions with people at a similar level. And I'm just so in awe of your true lifelong learner attitude. I think it's easier to have that lifelong learner attitude as a student and a resident when that's the expectation. But attendinghood, for those of you who haven't had it, often comes with the expectation that you should already know everything, which of course is not true. And I think you are literally the model of what we try to do with the clinical problem solvers, which is to illustrate that everybody is learning all the time. And I think no one illustrates that better than, in my opinion, a phenomenal and seasoned attending who still effortlessly says, hey, I'm learning more and more and more. You're an inspiration for me for sure, and I imagine for hopefully an inspiration for other attendings who frankly have lagged behind a little bit in our collective acknowledgement of the fact that we have a lot left to learn, unlike our student and resident colleagues who have jumped on that bandwagon. So thank you for being one of a few, and I hope you'll inspire other attendings to feel less and less inclined to pretend like we know everything. So thank you. I really, really appreciate that. Alrighty, my mic is yours, my friend.
Thank you so much, Vijay, for this case, and thank you, Rabih and Mengyu, for the wonderful discussion on PE and hypercoagulability and also the life lessons. So for this case, we started with a young patient who was 18 and who presented with worsening dyspnea. And we had to think, is it bad luck, bad behavior, bad genes, or bad environment? And it was important to also keep in mind the congenital and genetic causes. And in this patient who was young with sudden onset dyspnea and chest pain, we need to scrutinize the history because there is more to it. And Rabih told us that the deeper, that when chest pain is added to the dyspnea, we have to think about deeper problems like the pleura and cardiac causes. The PMH later revealed that the patient has a history of unprovoked PE. And the difference between provoked and unprovoked PE is that provokes PE is something that can happen. The existence of a severe underlying risk factor less likely. However, in unprovoked PE, we don't have the risk factor often, and we need very detailed workup. And this workup has to be agnostic to the PE, or as Ravi said in the chat, that we need to look behind the PE curtain. And we do this through, through detailed history, both family history and pregnancy history and personal history, and labs like factor V Leiden and antiphospholipid antibodies. And these labs need to be repeated in the outpatient setting because they can be false in the acute setting. And we can ask ourselves, why do we need all this workup if unprovoked PE will need lifelong anticoagulation anyway, but the importance relies in the importance of screening other family members, or maybe that is also important to know that the severity of PE does not influence workup. The CTP in this patient was indeed positive for PE, and the POCUS also found an IVC thrombosis. Mengyu taught us that in thrombosis, we have to think, is it vessel problem, like due to occlusion, or anatomical problem, or blood problem, like APLS or another hypercoagulable states. This patient develops PE despite being on rivaroxaban, and this makes us think about the two M's, either meds or mimics. For the meds, we have to make sure that the patient is really observant of his medications, look for drug-drug interactions, or a malabsorptive syndrome that can make his drug level suboptimal. For the mimic, we can look for other causes of filling defects in imaging that cannot always be thrombus, and these are tumor thrombus, for example, that can be resistant to anticoagulation. In addition to the two M's, you also have ultra hypercoagulable causes like occult cancer, polycythemia vera, eosinophilic myocarditis, like the case that we had with Mark, and compressive syndromes, or Behçet syndrome. And this patient had indeed a compressive syndrome. It was May-Thurner syndrome, and we have to make the distinction between the radiological finding versus the actual syndrome, because 90% of people with May-Thurner anatomy don't necessarily have the syndrome. We ended up with a combo diagnosis with VJ again, with both May-Thurner and APLS antiphospholipid antibody syndrome, since the labs returned positive this time. That's it.
Oh, amazing. That was a really, really tricky case to summarize. And I love how you hit all the highlights. Thank you so much, Amirma. It's so good to have you back in the teaching points sphere. All right, y'all. Thank you again, VJ. Thank you, Mengu. Thank you, Shreyas, for scribing, despite it being super, super late. We all thank you all and hope you have a fantastic day, and hope to see some of you tomorrow. Bye.